and welcome everybody. This is the Hawaiʻi State Center for Nursing Advisory Board meeting. We're going to start with our welcome and introductions. And Bree, if you could share the screen again. Oh, and here's Amy. Perfect. Perfect attendance. Bree, can you share the screen?
Yeah, I have so many windows open. I have lost the share window. I apologize for the delay.
Okay.
There we go.
Perfect. Okay, welcome and introductions. Mahalo for joining us. We are excited to welcome 5 new members to the Hawaiʻi State Center for Nursing Advisory Board. Your expertise, commitment, and diverse perspectives will strengthen our collective effort to advancing nursing practice, education, and workforce development across Hawaii. I want to welcome you all to your first meeting, and thank you so much for being here. And if you can wave and say hello when I call you, just so everyone knows who you are. We have Giovanna Oppo.
Aloha everyone, I'm Giovanna.
Thanks, Giovanna. Sarah Kamaka Viva Ole.
Hi, Laura. How are you? Hi, everybody.
Thank you. Hi, Sarah. Olivia Kim.
Aloha, everyone. Thank you for having me.
Tammy Napoleon.
Hi, everybody.
And Amy Thomas.
Good afternoon. Looking forward to working with you all.
And then I will complete the roll call with our existing members. Thank you for coming back and staying with us. Jeanette Ayers Kawakami.
Hi, everyone.
Linda Beechnor.
Hi, everyone.
And Sandra Leggy Brandon.
Hi.
And then we have our staff with us as well, or a few of them. Brianne Atwood.
Hi, everyone. I hope you can hear me. I probably will stay off camera so we save the space for the most important people. I'm here to support you.
Thank you, Bree. Carrie Oliveira.
Hi, everybody.
And Catherine Van Davis.
Aloha, everyone.
Thank you so much. And with that, we have quorum, so we can start our meeting. We will go over our agenda. So today on our agenda, we just completed the welcome and roll call. We will make our public testimony statements. Following that, we will hold a vote for our advisory board leadership and governance positions. As the existing members are aware, Anne Scharnhorst was our chair, and she actually completed her 8-year term, so she termed out. And then our vice chair, unfortunately, Gloria Fernandez passed away in December. And so with that, we have the opportunity for leadership, confirming our leadership today. The bulk of our meeting will be our annual report, our year in review. So this is one of the ways that we try to orient you and the general public. This is our short version. The long version is the very beautiful annual report, which I welcome you to read. And then we'll do legislative updates, address other business, confirm our schedule for the remaining year, and then we'll talk about upcoming events, and then we'll adjourn at 5:30. So our public comment period. Oh,
Laura.
Catherine.
Hi. So I just wanted to make my announcement and then I will.
Sorry, Catherine, we can't go out of order because of sunshine rules, but we will get there very shortly.
Oh, I didn't see me on the agenda. I apologize.
Thank you. No, we have you on the agenda.
Okay.
Yeah. Sorry about that.
Okay.
Public testimony. At this time, we welcome public testimony to ensure we conduct our business efficiently and provide everyone a fair opportunity to be heard. We will follow these procedures that are on the screen and also in our agenda. Testimony timing. If you are unable to provide testimony now, you will have another opportunity to speak when specific agenda items are called for deliberation or action. Identification. For the record, please state your name and organization you represent. Time limits. In accordance with board policy, oral testimony is limited to 5 minutes per testifier per agenda item. Visual option. Under Act 12, all remote testifiers have the option to be seen on camera while providing testimony. Connectivity. Please be aware that if we lose our audio-visual connection to the public broadcast, we will recess If it is not restored within 30 minutes, the meeting will be terminated and rescheduled. Public record, all testimony, whether oral or written, is considered public information and will be posted on the board's website for inspection. And we appreciate your cooperation in maintaining a respectful environment. The board reserves the right to remove any individual who willfully disrupts these proceedings. And please note that there has been some instances on other state reported events, and so we will do our best to manage a safe and respectful environment, but there has been some wild things happening. So I just want to give you that notice in advance. All right, so if we can move on to our first item, it is our board leadership and governance, and we do need to request an action. I'm going to call for public testimony, and if anybody would like to provide public testimony on this agenda item, please raise your hand. Seeing nobody in the room except for staff and our board members, we can move on. So at this time, we need to host a nominations for the chair and vice chair position. If you can put in a chat, if or you can comment if you would like to nominate yourself for either of these positions, and then we can hold a vote for each of those roles. These roles are voluntary leadership positions. The main activity is leading these meetings, the Center for Nursing Advisory Board meetings. You act as a spokesperson for the center when called upon, and assist in agenda for board meetings, agenda setting for board meetings. There's very little time expectation outside of these meetings, and we will work with you to help support and maintain all of our sunshine laws and all of the expectations of the board chair and vice chair role. So if there's anybody who would raise their hand for, oh, we have a comment from Linda Beechner that she is nominating herself for vice chair. Do we have anyone who would like to nominate themselves for chair? Did I see anybody's hand? Did I miss it? Let me see. Oh, my camera just went away. Chair position?
We have another chat from
Oh,
Jeanette.
do we? Oh, thank you. I have a delay. So sorry for that awkward pause. Awesome. So we have two people who are nominating themselves for chair and for vice chair. Jeanette Ayers Kawakami for chair and Linda Beechner for vice chair. We will need a motion to appoint these two individuals. Would anybody like to have a motion, or would anybody like discussion?
Motion moved.
Okay. Sarah moves. Do we have a second?
Second.
Thank you, Sandra. Sandra seconds. I will do a roll call vote for this one. So let me go get my piece of paper for you all. So I'll call each of you out by name, and then if you say aye for in support or nay for in opposition. Giovanna Oppo.
Aye.
Thank you. Jeanette Ayers Kawakami.
Aye.
Sandra.
Aye.
Sarah.
Aye.
Olivia.
Aye.
Tammy.
Aye.
Amy. Amy, did you say anything? Sorry, I was looking down. Sorry, I was looking at my
I did. I said aye on
Sorry
mute.
about that. Thank you, Amy. And I just want to note that we have also welcome Clementina Soria Ulap, who is our ex officio member. But with that, we have our chair and vice chair. Thank you so much for.
I didn't get to vote.
Oh, Linda.
Need to put me on there.
Oh, sorry about that. Linda.
No. Yes. Aye. Thank you.
Thank you. Thank you so much. Sorry about that oversight. All right. Well, thank you so much. I will continue with this meeting, and then we will resume our chair and vice chair roles at the next meeting. I won't I won't slap you with an opportunity right here in the present. So we will continue with the meeting as it is running, but we will be touching base with you, and I'm so thankful for your additional leadership support. So thank you. And with that, I will just say we have Jeanette for chair and Linda for vice chair. So thank you so much for that confirmation advisory board. Also on this agenda item, I want to just thank in advance Brianne Atwood Kuwabara. She has done a tremendous job putting together all of the many new rules and regulations that we have to abide by. I think she did it in a way that is very kind of like we can swallow it. It's easier to understand and to follow. So thank you very much for that consolidated rundown of the protocol that we have to follow. So we have all been provided the training packet regarding the recent amendments to the Hawaii Sunshine Law. Because we are a governor-appointed advisory board, we have to follow these sunshine laws. So please do mind the sunshine laws and the state ethics codes as they pertain to the Hawaiʻi State Center for Nursing. And as we get updates and further guidance, we will make sure that we're providing that to you all as well. Does anybody have any questions about that?
I also want to add really quickly, Laura, that there's also, in addition to the education packet, which is currently still under review, you will be receiving it this week. Please make sure that you do take the time to take it. It's intended to be digestible. There's audio as well, so you can listen to it in the car. It shouldn't take more than 15 to 18 minutes, I believe. And there's a lot of cheat handouts. So we have them for the chair, we have them for the vice chair, and we also have them just kind of generally for the board as takeaways to make life easier, since, you know, it's a lot if it's your first time. So I just want to make sure everybody feels supported and everybody is updated on what they need.
Thank you very much, Bree. All right. Moving on, there is a little bit more information about the state ethics code, and there is an additional training on the state ethics code. As an advisory board member, you are not required to do it by state law, but it's short and it's easy, and it's always nice to know where the boundaries are. So I do recommend it, even though it is not required.
And the links are also in your education packet.
Yes. Thank you. All right, we are on our second agenda item, our annual report, year in review. As a new agenda item, if there is any call for public, or I'm making a call for public testimony, if anybody in the general public would like to provide testimony now, please raise your hand. Seeing nobody in the general public present, we will move on to the content of this section. So in this section, we are going to give you an overview of the annual report. And if you haven't gotten a chance to read, again, I do recommend it. It is a nice report, and we greatly condensed it this year. So it's not as long as it's been in years past. We hope it's a little bit easier. First off, I wanted to just talk about some kind of like big high-level overviews. So if we go to the next slide, or the next two slides, actually. So with the strategic planning, many of you had the opportunity to engage with us, all of our existing board members. We did a large undertaking of our strategic plan we used an appreciative inquiry process that led to the development. So we did discovery groups using appreciative inquiry that led to the development of our strategic plan. This 2-page, or it's a 6-page fold-out document is also available online. And with that, our priority areas are advancing education, advancing leadership, and professional development. So those are the 3 priority areas, but we also have all of this robust information from our discovery sessions that we can use to drive our activities and our initiatives. Next slide. With that, we also updated our mission and our vision. For those of you who are at our 20th anniversary celebration, you have this information already. Our new vision is a protected and elevated Hawaii nursing workforce, and our mission is to collaborate on fostering workplace conditions that support and engage nurses to remain in a fulfilling profession. And we really focused on that workplace conditions, because we are nurses always, for those of us who are nurses, but we're nurses always. But it is the focus of the Center for Nursing to look at these strategies for the state for recruitment and retention. So think about the personal responsibility, professional development, leadership, as well as the professional environment that we come into at work. That's kind of the area that we're looking to influence through this work. Our next slide, if we can go to that, is we have some updates as well, which Catherine, I believe this is the section that you are hoping to talk about. So I want to, and you may have seen this in our newsletter as well, as we were kind of closing out the strategic plan and the year's work developing the new strategic plan and looking for the opportunities forward. Catherine has decided to focus on her many busy other two hats, her primary roles at the School of Nursing and also at Queens. And so she will be stepping down as the Associate Director of Evidence-Based Practice. And with that, Carrie has agreed to assume more responsibility here at the center as the Associate Director. The Associate Director role will look different, but I just want to thank Catherine for her 9+ years as the Associate Director and welcome Carrie into her new role.
Thank you, Laura.
Yeah.
I do want to tell everybody that I think evidence-based practice, y'all have seen my face in that realm forever now, and I think it's in a very good place for the state. There's a lot of things in place at the center that can live on, and Leanne Hussey is taking over day-to-day, week-to-week monitoring and planning with evidence-based practice. So you are in excellent hands with Leanne. So I'm not going anywhere other than the School of Nursing. So I'm here. If you need me, let me know. And otherwise, please feel free to reach out to Leanne if you have any needs from the center standpoint. Thanks.
Thank you, Catherine. And Carrie, you are up next. So I'm just going to let you have the stage at this point.
Yay, cool. Really excited. So I appreciate that. I hate to see Catherine go. But one of the conversations I had with boss about kind of the associate director is she spends a lot of time looking from inside the center outward. So I feel like my job will be kind of to focus on inside the center. So kind of helping to provide some coordination between our programs and really move toward so kind of keeping an eye on the strategic plan, basically our outcomes. And the role will evolve over time. We haven't quite figured out exactly what the whole totality of the job will be over time, but I'm really excited. I appreciate the vote of confidence my colleagues expressed to me when they basically sort of like voted me into the job spontaneously. That was fun. So that's exciting. With that, I'm still the researcher though. And so I'm going to give you an update about research, I think. Yay, nursing workforce data. So I have a little bit of time to talk to you folks about things that we've done in the past year-ish, I guess. We kind of operate on a fiscal year when we report. So the first thing I want to talk about is our education capacity survey. So for those of you who are not familiar, our education capacity survey we do on an annual basis. It's a survey of all of the board-approved nursing schools in the state. So they have a physical presence here in the state. So we don't survey the schools have like only online presences. The schools, 100% of them participate since 2016, 2017. It is amazing that they're willing to do this for us. So the outcomes I think are notable. The survey just kind of runs, it goes annually. We're getting ready to put the 2024-2025 survey into the field in the next 4 to 5 weeks or so. So we're getting ready to launch that. So these data are from our 2022-23 survey, because that's the one we reported in the fiscal year for the period of the reporting for our annual report. What we noticed there is that our LPN enrollment capacity increased substantially, which is in large part thanks to the UHMC CNA to LPN bridge program. That really kind of facilitated that collaboration between academic partners and the school to really funnel CNAs into the LPN role. So that has proven to considerably increase both capacity and has resulted in more graduations from the LPN program. So that's really helping to bolster the availability of the LPN workforce in the state. Still, it is the case that enrollment exceeded capacity or enrollment demand. There's a missing word there. Enrollment demand, that is the number of people who applied for nursing programs, exceeded the capacity in pre-licensed programs. That's both ADN and BSN. So still there is very strong interest in nursing as a profession. Schools obviously cannot accommodate everybody who is interested in being a nurse. And also there's, we have to balance the number of people we admit into nursing programs against workforce demand. So it cannot be that we just kind of like continually increase education capacity without having an analogous plan for can the workforce absorb those new graduates. So this is one of the important functions of this survey, is to kind of monitor that against how many new grads our employers are planning on hiring. Our full-time faculty vacancy rate was down 13%, which was down from the previous year, but it is still it's almost twice what the national vacancy rate is for faculty. And we know that this is a challenge, especially on the neighbor islands, recruiting to faculty positions on the neighbor islands, especially at the community colleges. The pay at the community college level, especially in the neighbor islands, is not commensurate to the cost of living. And so it makes it very difficult to recruit and retain full-time faculty. So that's something that we're continuing to monitor. School's most significant challenge is recruiting and retaining faculty into full-time and part-time positions, and then securing quality political training sites. This is historically the case. So we're not really seeing any material changes there. So that's really kind of the highlights of what's going on in education. So the next thing I want to talk about, I'll take any questions actually, if you guys have any about that. So big picture takeaway, we have sufficient capacity and enrollment demand to keep pace for RNs and APRNs, LPN capacity, though, and recruitment and retention of faculty are notable challenges and will probably continue to be so. So up next is supply. Yay! In every odd numbered year, in conjunction with nurse license renewals, we field our nursing workforce supply survey, which is my favorite part of my job. This year was huge, biggest year we've ever had in terms of completions. So we had 16,731 attempts or starts on the survey. When we cleaned and deduplicated the file, we had 15,532 completions. That's a lot of records. So huge. Disproportionately represents nurses who work in the state. So people who are outside the state oftentimes have licenses in other jurisdictions. They participate to a lesser degree. So this is a really huge sample of nurses who actually work in the state of Hawaii. So it is the most robust data set that we have about the nurses who work in the state. Our statewide data tables were published, as well as our technical documentation. I literally 4 minutes ago got an email from a graphic designer who has sent me a revised version of our statewide supply report. So in that report, we provide data by county, because Oahu is not the whole world. We have to make sure that we're drawing attention to neighbor island concerns, and we make sure that we do that in the data tables. But also the other function of this report is to provide commentary on the state of the workforce. So we talk about the LPN shortage, how RNs are basically in equilibrium, though we do have workforce concerns on the neighbor islands, and that we haven't really, what we're looking at is an underutilized APRN workforce. And so all of that commentary is there. We're probably going to do a couple of webinars to hit the highlights on that to disseminate the information more widely. So that's that. Big picture takeaways on that. Biggest, most comprehensive body of data about Hawaii's nurses in existence, really, truly. So thank you to all of you nurses who participate in the survey. And we'll be continuing to push out more data from the survey, various subsets of the data over the next 12 to 18 months. Up next, our nursing workforce projections. We did these now a couple of years ago. I feel like it was just yesterday. We spent a lot of time getting it done, and then now they're in the past, but they continue to provide really important insights. If you haven't read our projections report, it's a big, big, unwieldy report. There is an enduring webinar on our CE portal that I sort of like hit the highlights and strip away, make the graphs a little bit easier to read. So if you'd rather consume the data that way. But basically the upshots are that we have an extreme shortage of LPNs that is expected to continue and worsen through 2037, even with the expanded education capacity in LPNs locally. We cannot endure a loss of capacity or enrollments in local RN programs. That could push us into a shortage, as could the situation if we see people retire earlier than we would anticipate based on their age otherwise. So supporting the retention of our workforce is really important. Supporting the ongoing sustainability of our local nurse education programs is crucially important. But right now we're not in a shortage situation on RNs. And so we don't need to be expanding RN capacity. We also, again, our data, the projections will say that we have an oversupply of NPs, but our interpretation of that is that they're underutilized, especially when you compare NP practice in the state of Hawaii to the nation. we have way fewer of them in private practice. We have way fewer of them who are primary care certified, who are actually providing primary care. And we continue to have a primary care physician shortage in the state. So if there's a way for us to tap into that APRN workforce to push them into practice, that would be better. We have the available supply. And our neighbor island counties continue to have fewer nurses than they need, while Oahu has more than it needs. So we really need to work on distribution of the workforce rather than a bigger push to produce more nurses in the state. So those are the big highlights. I talk about this a lot on our webinar. So if you're interested in that. So we are using the projections in particular to be forward thinking in our workforce development efforts. We cannot always be reacting to what is currently happening now, especially since it takes a long time to make a nurse. It takes like 3 to 4 years to make a new nurse. And so it doesn't make sense for us to only be looking at right now and expecting to project that into the future. So these assist us in that effort. And I think that's it. Other workforce reports. There's just stuff that we do. People are really interested in new grads. We did our active licenses from 2014 to 2024. There's some really interesting insights there. The proportion of nurses who hold an in-state license but don't live here is growing over time, and that has really interesting implications for our interpretation of available workforce. We also did kind of a fact sheet about what out-of-state nurses are doing. So those nurses who don't live here, what are they doing? They're not really part of the viable workforce. So we continue to provide, if you can advance the next slide. We continue to write reports based on questions that we get and things that we think are important for people to understand about the workforce, to clear up misconceptions or to provide additional data where people are like, what's happening there with the workforce? So we have a ton of data. We are happy to disseminate it. So if you have a question about the workforce that you don't see an answer to in our reports, send me an email and I'm happy to assist. Any questions?
Yeah, we have a question. So
Hi, Clem.
you said that there's no shortage of RNs right now. So how about long-term care? Is there shortage there or what?
When we talk about the workforce, we talk about the whole available supply of workforce.
Mm-hmm.
So when we count the number of registered nurses we have relative to how much healthcare the state would need,
Mm-hmm.
we consider our supply to be adequate. That is not to say that we don't have recruitment challenges.
Mm.
So there are definitely some settings, long-term care being one of them, that is probably the hardest one to recruit into. So I think what we would, in our conversations about workforce, I would really like to see us start shifting away from talking about a objective nursing workforce shortage, instead talk about what can we do to encourage a improvement in the recruitment situation into hard to fill settings.
Correct.
And we know there's some data that indicates there's a pay disparity, right? So acute care nurses are the best paid RNs in the state. Acute care, long-term care, there's a big pay disparity there. There's a pay disparity relative to the neighbor islands. So I think these are the sorts of things we can continue to illuminate about why it is more difficult to recruit to certain settings as opposed to others.
If I can add, when you look at carry supply data and you can look at care and the projections, you can see that, for instance, neighbor island is equally, or it's proportionally distributed. So you can say like the population on Kauai is 12% of the state population, and the population of nurses on Kauai is 12% of the state's nurses. But you have an over demand of nursing services as compared to the population size. And so these are, so you can say, oh, we have enough nurses in the state, but then when you look at how much nursing demand there is, that's when we're looking at state strategies for recruitment and retention. Then we need to have different strategies for different communities, because, for instance, looking at the population distribution for Kauai is not good enough for Kauai. And then we have overrepresentation on Oahu because we have the sickest people historically have come into Oahu for this greater amount of care. And so, those kinds of things, like where is there concentration of nurses and where is there less, where is it more diffuse? These are the elements. So that doesn't mean we have a statewide shortage, to Carrie's point. It means the distribution and the recruitment and retention strategies need to be right tuned to the specific needs of these different communities and settings, et cetera.
Related to that, when the statewide report comes out, I did link to a UHERO report that talks about the inefficiency of building a healthcare system on the neighbor islands. So the geographic distribution of the counties has a really significant impact on the development of things like workforce. And so there's a really interesting, I didn't comment too much on it, but I think if, understanding how it is difficult to create workforce on the neighbor islands, I think there's some insights in that report. So I would also point you to that for neighbor island issues.
All right. Quality practices, and I can't ever say this right. It is.
You can't even read it right, Bob.
I can read it right. Best practices and quality outcomes is the next section of our work. This is our second mandate. I will be presenting on behalf of Leanne, and this is also the work where Catherine has done work as well. And so for nursing professional development, we are an ANCC accredited provider. We actually gained reaccreditation in this past year as well. Because of our data reporting, we reported on the 2024 calendar year instead of the fiscal year, which is, like July to June. But we offered 11 courses, issuing over 8,000 contact hours to nearly 600 participants, 95% which were nurses. And back in 2015, we helped pass the continuing competency requirements for nurses. And then as a priority of the advisory board was to become an ANCC accredited provider so that we could make sure that the community had access to high quality continuing education credits. And so I certainly think that we are making that goal. We also were able to increase our organizational efficiency by moving to a learning management system that is it's going over a new kind of upgrade right now. Hopefully, if you have used it, you find it easy to use. If not, let us know because we'll work on it. But it also holds everybody's CEs for the content that they've used through either our podcasts, our webinars, or our conferences. And so it is a repository as well that makes managing your CEs a little bit easier. Next slide. The take home again is that we are working to maintain good quality CEs. We're fostering relationships with our community partners and nursing associations so they can also provide their CEs, and that we're committed to providing that high quality evidence-based content for learners. Next slide. Our evidence-based program, and this is Catherine gave a little bit of this comment earlier, but one initiative that she launched over this past year was a novel concept. We've done a lot of evidence-based workshops over the years. This past year, she actually took 4 organizations through one statewide EBP project. So they did all of the lit review, they ideated a project based off of the literature, and then they implemented it differently in their own facilities based off of their organizational design. And so there was a focus on wellness. The specific topic was hydration for nurses, but that has some great success and it's already been accepted to a conference that we will be talking about later in our presentation. And then we also have an online repository, and this is meant to be a sharing resource. So if you have an EBP project, you can put in all of the different contents. And so, if you're at a smaller facility and you want to see, well, what have people done in falls, you can find your colleague, but you can also see how far they got in their work and maybe pick it up further. Could be a good resource for students, also a good resource for professionals. And so we soft launched it, and we're still working on getting those activities put in to create that kind of that strong collaborative environment that we're hoping to build through that resource. Next slide. Oh, thank you. So we are changing our EBP program, and as you can only imagine, with Catherine stepping out of the associate director role, the good thing about Leanne is that she leads our nursing professional development, and she's very engaged in a number of other programs and has been around the center for a long time. So she's imagining how she can continue the EBP in new ways, and working with our other existing programs so that really kind of folding in and strengthening that relationship with EBP kind of as it relates to education, entry to practice, and continuing professional development. Next slide. And I mentioned, really Carrie should talk about this, but I mentioned that I was alluding to an event coming up that actually, Carrie, you should legitimately talk about this. This is our event.
So our Hawaii Nursing Scientific Symposium is amazing. Our 2026 event is coming up on February 27th. It's sold out. We're trying to figure out how to squeeze a few more people in, but it's mostly sold out right now. In 2024, we did this for the first time in response to a gap. There was no place for nurses to disseminate across the state the work that they were doing in terms of their own original research or the translation of science into practice through EBP or programmatic innovation. So we decided, you know what, let's make this happen. So we did. We put it on for free the first year. We had 73 nurses attend. We have 120 who are going to attend this one. So it's a huge growth. So those are the big takeaways from our last one. We had a bunch of abstracts submitted. We're doing our inaugural awards this time around for nursing excellence, outstanding nurse researchers. So really excited about that. I don't know what's on the next slide, Brie. Really, our goal here is to help foster community locally for nurses who are engaged in inquiry, the development of research and translation of science into practice. And really, we want to foster this like opportunity to disseminate across the state. We do a lot of dissemination within organizations and then from Hawaii out to the nation. But really, this is the thing that we want to do is encourage the dissemination within the state. So stay tuned for more information.
All right. And then Nursing State Simulation Collaborative is an initiative that initially was requested by the Manoa School of Nursing and Queens because they were facilitating and supporting many other simulation providers across the state. And so we've had various activities over the past, maybe since 2021. Throughout 2024, we were really in a reassessment phase because we were doing strategic planning at the end of the year, but also because we had a very large conference. And then there was a little bit of a lull. It was like, oh, my appetite is full. And then we were waiting for the community to come back and start communicating to us. There is primarily an interest in really pulling down resources for the state. And so what we ended up doing is joining the Western State Simulation Alliance, which is California's simulation alliance. Ended up getting requests from Washington and Oregon and Colorado and all of these other Western states who are saying, you've really got a lot. And our alliances have kind of struggled, that post-pandemic struggle that I think every organization went through and every volunteer group has gone through. And so, but California stayed strong. So the Western states merged together, and then we were offered as the furthest west state, perhaps. But we were offered to be part of that community as well. And so we have joined, and by joining, we have been able to push out resources as well to our state providers and states in state. So we are really now exploring what resources we have and how, and if we are going to customize those resources on behalf of the state in this community of the Simulation Collaborative. So our take home is that this is really a goal to connect our strong simulationists, nurse faculty, and the simulationists, nurse educators to these evidence-based resources that are well developed, that are bound in science. So there's a science of simulation, and then there's also nursing. And so we really want to enforce that and strengthen that in our community. And that national partnership that we have is aiding with that. If we can go to the next slide. We also have clinical faculty training. We got recurring funds from the legislature. We have $27,000 annually that we support for clinical faculty. And that was coupled with some state funding that went to all of the UH programs for clinical instructors. But when we saw that we needed more clinical instructors, we said, well, we need to make sure that they have professional development as well. And so this past year, we convened our deans and directors across the state, private schools, and our public institutions, and they also prioritized that simulation training. And so with that Western Simulation Alliance, then we purchased additional specific trainings, both for clinical instructors and for simulationists, so they can really support that strong learning environment for students before they go into the clinical setting. And then we also purchased a license. It's a statewide license for Nurse Tim, which is like an online repository, webinars of specific for clinical and didactic faculty, specific for nursing faculty. And that is on demand. So each dean or director in the state has an administrator account, and they are able to give all of their full-time, part-time, and graduate students, full-time faculty, part-time faculty, and their graduate students a license in the state. So it's very cost reasonable for the Center for Nursing to cover that, and we covered that in part with its $27,000. But then it gives that point in time education where it includes like how to create a survey, how to create a test, and And then it also has like having difficult conversations about remediation with students. So it really runs the gamut, as well as specific clinical content as well. So our take home for that is that faculty have unique learning needs, and then we're working to support that through a variety of touch points with the deans and directors and using standard national tools that can kind of support people when they are ready and available. Our recruitment and retention section is next, and Bree is primarily the agent of change for that section. So Bree, did you want to? Yeah, there you are. We'll let Bree give her updates.
Okay. Well, we've got a big group of folks that are new to us, so I don't know how well they know some of these other programs if it doesn't really impact them. So from the academic side, we have the Hawaii Clinical Placement Collaborative, where we are working to help to support clinical placements across our state for education of nurses. We work closely with all of our partners in order to get that done. And the biggest thing is that we have this wonderful, amazing group of people that work really well together to fight through some very difficult times over these past few years. Overall, the program is doing well. We have a lot of things on our docket this year for areas of improvement because we have finally gotten to a point where we are stabilized. So we can look to the future and try to close some gaps. But overall, we're seeing kind of a nearly a 6 percentage point year-over-year increase in overall clinical placements, which is a really good thing because we are increasing our enrollments. We are also seeing, as relative to that increase in our total clinical education hours, rotation types, those are remaining relatively stable, meaning that the distribution between the two types seems to be commensurate. We did go through some things during COVID where the distribution of cohort versus preceptor-led placements was a little bit disturbed by COVID. And so what we were doing is kind of cohorting our preceptors, which made a lot of extra work for a lot of those nurses that were providing those preceptor services. But we're at a point where that isn't happening anymore. Our student to faculty ratio, we've seen it steadily increase over these past couple of years post-COVID. However, in 2025, it went down from 6.3 to 6.1. It's a pretty small change overall. As long as we can have it be above 6 and maintain it above 6, it's a lot better than we have been doing for a long time. Obviously, even at 6%, it does continue to place a pretty heavy burden on our faculty and on our schools of nursing in order to be able to provide the clinical faculty necessary to handle those cohort groups that are so small. We continue to see peds, OB, and psych to be areas of concern. We could call it constraint, but really it's concern. We're working pretty diligently in a kind of group capacity to be able to make sure that our schools are all working together and all of those needs are met. It can be really kind of difficult when you have a very small pool of options for those clinical placements, but it's amazing what they do when they put their heads together and manage to make exchanges and returns and all sorts of other things to make sure that everybody gets what they need. So kudos to a great group of folks. Overall, the take home is that we're doing a good job. We've been doing a good job for a while. It's finally stable. And what we're hoping to do this next year is to really kind of focus on the next step. For a long time, we wanted to increase our capacity for requirements and onboarding management. So those clinical requirements, those educational requirements, the methods in which we're keeping track of those and processing those. So we're hoping to address that this year robustly. And also we're looking at really kind of trying to legitimize and solidify a allied health pilot for the use of CCPS, which is the software that we use, so that hopefully we can work to make sure that we're doing that as robustly as possible because we would like it to become the norm. Whether or not the center joins forces with allied health in the long run, we don't know how that's going to look. But if we can do the testing and make sure that it's robust enough, it should save a lot of time and human resources for the schools and facilities that are participating in that. So exciting times ahead. The Hawaii nurse transition to practice. This thing has just kind of like blown up in the past couple of years. It has just, not only has it blown up, but it has just blown out as well. So what we see is that we rebranded a couple of years ago. We added a bunch of appendages to these programs to expand them. So we're covering specialty in addition to nurse residency and looking at we have long-term care as well. If you're interested in all the nitty-gritty on the individual program level, see the annual report. Overall, one of the most exciting things that happened this past year was the fact that we were able to host for the very first time a conference devoted entirely to transition to practice. So we got all of those folks down to the coordinator level that normally do not have the opportunity to participate in conferences, let alone conferences on the areas in which they work. So exceedingly grateful to the center and to ADAD, which helped to support those education efforts. And we have fingers crossed that this opportunity will be dovetailed into the conferences that we already have. So the research conference. So hopefully every couple of years, they'll consider us as the topic and we can work on it in that way. Obviously, funding is always an issue, but that was my pitch to Carrie. Like, don't forget me, Carrie. Okay. We continue to produce workforce briefs. I encourage anyone that's interested in learning about how these programs shake out to look at those resources. They are pretty meaningful resources. There's a lot of data in it. Carrie produces lots of data. I also produce data, maybe a little bit more pointed. It's not representative of the whole state, but certainly of the people that are putting in the effort that I have access to. Let's see, the biggest thing, we managed to have a 5th year running for partner funding to offset almost over the course of the 5 years, almost 100% of the direct costs related to the curriculum purchases for our nurse residency program for all of our partners. It's a really, really, really big thing. It currently is at 1.3 million that we've been able to distribute through that. We are so grateful that we had the opportunity to participate in receiving funds and then being able to distribute those funds in a meaningful way to all of our partners to help kind of reduce the cost of their education to allow them also to focus on other things with those funds if they had other funds available. We do have it for this year. No telling if we're going to have it in the future, but we're just trucking on, making the best of everything that we have. We did manage the most exciting thing that happened with all of these programs this past year is that we reached and exceeded parity for our rural island communities. And when I say that, when we compare the working nurses in our state that are living in those communities, the distribution, we managed to provide more resources to our neighbor island communities for direct education than we have that distribution of nurses. So we exceeded parity. What the hope is we continue to do so. That influx of extra resources in communities that have been historically underfunded and under-resourced will hopefully help kind of work to achieve a closing of the gap for them or continue to provide an alleviation of stresses for those communities. So should be
If I may
exciting.
add,
Yes.
if I may add that we have gotten news that the Rural Health Transformation Program has dedicated funding specifically for rural health. So we think that we will, all those contracts are like up in the air, but we're hoping to continue that specific focus on rural health transition to practice support through that funding. And that would be at the amount of $400,000 per year for 5 years, so long as that grant funding is renewed annually.
Fingers crossed for us. Overall, we're doing well. We have improved, we have expanded, and we will continue to work to secure funds to help offset these educational activities and to support them in other ways wherever we can. And hopefully we'll see a higher number of long-term care and post-acute happening in the next year, fingers crossed, and also continue to look at that exceeding of parity for our rural communities.
Thank you, Bree. So I got a couple slides and I think they'll be pretty brief, and then I'll just make sure that we have a minute or two for any questions or comments for this very dense section. So thanks for staying in here with us. For nursing policy, one major initiative that we've had is reviewing the House asked the Center for Nursing and a couple other entities in 2022, 2023, do you really need to change all these laws related to APRN, barriers to practice? Like, and they asked, they went to the employers and said, do you really want your nurses doing these things? And they went to the medical association and they said, what is going on in healthcare? So there's a sense of curiosity. And so and they were also asking the Board of Nursing, but the Center for Nursing has more administrative resources than the Board of Nursing. So we formed an interprofessional working group with medicine, psychology, pharmacy, PAs. Is that it? And the many different groups of APRNs. And we reviewed 529 statutes that are related to healthcare outside of the scope of practice statutes. We found that in the majority of instances, the language no longer matched what our scope of practice was established in state law. And so we would look at each of us. So nurses would be like, does this match our scope? And then physicians would say, does this match our scope? And, psychologists said, would this match our scope? And so we looked at each of our scope of practice as it is established by the legislature today. We then we sent out that list to state agencies and to other health, to our own organizations and other healthcare organizations and employers. So we sent it to employers, insurance, state agencies, professional associations, and we said, do you see problems with what we're finding? Do you have other recommendations? Did we miss language? We took all of their edits, and then we went to Linda Ichiyama. She helped us work with legislative drafters. They drafted a bill. They provided additional round of technical recommendations, like don't break federal laws, which we knew that was outside of our scope. But so they were like, you can't do that because of a federal law, or this is uniform law. You shouldn't change uniform law. We then took all of those edits, went back to that same healthcare community, asked for another round of review, and we now have those two bills that are a House and Senate bill is going to, we hope, move through the legislature. This was huge. This was actually a 2.5 year effort. Actually, it was 3.5 year effort. So this was a very big undertaking, but the impact should be, if it passes, that people who are licensed should be able to work to the full extent of their licensure, and it should remove this administrative burden of always having to go to the legislature. Hopefully that will free up the legislators' times to address very big issues that are going on. It should free up our time as people in practice, people in policy, people in administration, from having to kind of keep track of all of these logistics. So if we're able to be successful with this, I think it would improve healthcare for the better, not just for nurses, but for the people who receive healthcare from nurses, everyone. So that was our main issue. We also have been doing more education and outreach with our APRN community, as well as our RN community, with a number of education activities and conversations. That said, and we will have another section about policy in a moment. The legislature just opened session last Wednesday, so we'll have more conversation with the advisory board in a moment. Our next initiative is the Preceptor Tax Credit Assurance Committee. We established a working group in 2018, drafted the law. If you can go to the next slide, Bree. We proposed testimony or legislation, we also found that there wasn't enough existing evidence to support a preceptor tax credit program. So Carrie ran a statewide survey based off a national survey that established the data, so the evidence-based need, and wildly we got this law passed, and now we run a tax credit program. And so in 2024 tax year, we had 311 preceptors and 664 tax credits at $1,000 per credit. Bree just completed the numbers for this past year, 2025. So we had 301 preceptors and 639 individual tax credits. And we're also working to change the law because it is restricted to primary care only. And so we're trying to both add additional professionals and add specialties within the existing professions, which are APRN, physician, and pharmacy. The main goal of this has been to recognize preceptors as well as grow the preceptor base. You heard from Carrie, you also heard from Bree that there is a constraint in that education space in different ways. And so we have also been able to demonstrate through our data collection that we have grown our preceptor base through this program over time. And we can skip through the take home. And then lastly, in this section, improving visibility, and we are doing a tremendous amount of work. You can see it in the annual report, and you can go to the next slide as well. We have done just a tremendous amount of work working with different organizations and associations, being on committees, both nationally and locally. And then we also host a number of meetings. We have an LPN, we don't host the LPN initiative, but we're part of an LPN initiative. We host the clinical placement initiative. We host meetings with deans and directors and CNOs. We just started a kind of talk story for nursing professional associations through the policy. So we're really working to both support the nursing community and then be part of the broader healthcare and education community, so that we are well positioned to understand the issues and also then develop strategies to support recruitment and retention of nursing in our state. So with that, we can take a breath. And also, if you have any questions or comments, I just want to provide a little bit of time for that, because that was dense. So just if you have any questions or comments, I do welcome them. All right. Hearing none, we are up on our next agenda item. So I will ask the general public who may or may not be with us, if there's any testimony they would like to provide. And seeing no members of the public with us, we will move on to the agenda item. As I mentioned, it is the start of the legislative session. And if you can, I really do hope that we can actually engage in dialogue now. There are two initiatives that I just mentioned that have been working on. And so these two initiatives, we do have two bills, a House bill and a Senate bill for each of them. Because of these are Senate initiatives, this is more just information for you to know about our efforts. If you have any questions or comments about these initiatives beyond what I just presented, I please welcome it. And also, any questions or comments about the information provided, or if you have any ideas, please, I welcome commentary. Oh, sorry, my computer just changed colors. The interprofessional HRS barrier, as it relates to policy, the Center for Nursing's position has been that when there are good laws that support practice, that it makes for a more welcoming environment. So it supports recruitment and retention. And when we see that nationally, we can see that, for instance, when full scope of practice laws pass in states, the proportion of nurses actually increase. So we see more APRNs where there are favorable practice laws. And then unfortunately, we have seen in the post-Roe era, for instance, that when there are unfavorable or unsupportive laws for, let's say, the perinatal space, then we are seeing now like OB-GYN deserts and hospitals closing their maternity wards. And so when there are unfavorable or unsupportive laws, it actually is a deterrent for recruitment and retention of healthcare providers. And so that's the space that we have been working in, trying to make sure that's the rationale for primarily this interprofessional barrier. And then for preceptor tax credit, generally the educational model in nursing and absolutely at the time when this was passed is that clinical education is kind of written out of everybody's budgets. So the schools generally don't pay clinical sites for their clinical education. That's a national model. It's actually seen as a best practice in nursing. But that doesn't change the demand to be part of that revenue cycle on the employer side. And so it's caught between a rock and a hard place. And so one of the initiatives or one of the premises with the preceptor tax credit is that if we create a financial incentive, particularly in a high cost of living state like Hawaii, we might kind of loosen up what is a constrained environment, which is that advanced practice level preceptor role. The preceptor tax credit does not address LPN or RN level education. It is only addressing that APRN level education. And so it is not a solution for the entire challenges with clinical education, but it has helped with that one. Any questions there? All right. Thank you. Next slide. The other two initiatives, and when we were preparing this slide, when we were preparing these slides, the bills hadn't been introduced. I was just on a call earlier, and now they're available. So the nurse staffing bill, and I did ask for any questions or comments. The nurse staffing bill it's an effort to address nurse recruitment and retention through a legislative staffing initiatives. Part 1 is a preamble. It establishes the case. Part 2 establishes nursing staffing committees, legislatively mandated under the purview of the Department of Labor. Part 3 proposes to change the composition of the advisory board of the Hawaiʻi State Center for Nursing. So we have 5 members who are in Group 1 who must be a nurse, and we have 4 members who are in Group 2 who basically can be a representative of anyone who can provide advice to the Center for Nursing. So it is not nurse required. The change is that in addition to one of the criteria in Group 1, so it's APRN, nurse executive, nurse researcher, or a doctorally prepared nurse researcher or educator, and a representative of a collective bargaining unit. So in addition to that, Group 4, or Group 1, which is 5 members, Group 2, which is 4 members, can be anyone. The recommendation is to add 3 additional seats that are specific to only a representative of a union who's in kind of like in an elected role, so board of trustees or in a governance position for that union. The process would not change, so even if it's restricted to that small group of people, it still requires the governor nomination process. So it would not change the process to become nominated and then appointed. So the same process that you all went through. And then the last section, or the 4th section, is to change the mandates of the Hawaiʻi State Center for Nursing. So we currently have what I call Carrie section, which is recruitment and retention, Leanne section, which is, I'm going to say it wrong, but it's quality practices and best outcomes. We have Bree normally does the recruitment and retention, and then Amy and I support that as well with the policy and community outreach. And so this proposal is to add a 5th mandate that is specifically creating a dashboard of safe staffing standards on a publicly available website. And then there's some fund allocation for that. So if there's any discussion, I do have some of the resources, and we can talk about each of those resources if you're interested. But if there's any discussion, I would welcome that as we look to draft our testimony.
So how many members do you have right now in the advisory board?
We have 9 members. There's
9.
currently one vacancy, so we have not 8 appointed at this point in time with 1 vacancy.
So the recommendation is to add 3 additional to the 9
For a
And
total of 12.
for a total of 12, and that would have some connection with unions. Is that what I understand?
That's correct, yes.
Okay. So this was brought up by a particular group, or
It was introduced to me as a concept by Hawaii Nurses and Healthcare Professionals, which is the Kaiser Union. And then I believe they've been working in concert with all of the unions together.
Mm.
Linda, I think you have more. Are you unmuted?
And and Hawaii American Nurses Association is working with this coalition of union members. And the intent I believe in the extra members being from unions was to insert more registered nurse, staff nurse input to the center, to the center's work, in order to connect nurses more directly with the center. In that the feedback that we were getting is that they don't feel connected to the center or to the center's work. So that's where that came from. Is that your understanding too, Laura?
It was communicated to me a little bit differently. It was communicated, there is a conversation about the visibility of the Center for Nursing, but it was more that they wanted the specific representation from the leadership who had kind of like a commitment to the unions. So the specific language is 3 members who are elected officers or governing board members of labor organization or governing board members of a labor organization representing registered nurses in the state.
And those folks can be non-nurses or specifically need to be non-nurses, or what was outlined?
It actually does not say that they have to be nurses. It says 3 members who are elected officers or governing board members of a labor organization representing registered nurses in the state. So without my knowledge of their eligibility of being elected officers or governing board members, I guess they could be, I'm thinking like HGEA, right? They have the units, but they have their governing board members, I think, are not nurses. So yeah, they may not actually be nurses.
Laura, I haven't had a chance to look too much into this at all, but just the general concept that I think has been shared with the staffing committee format seems to be modeled after some practices in the state of Washington, I think. And I'm wondering, does the center in Washington state have any outcomes yet from that implementation, or is there something we should be looking at there as you're looking at the center's response or stance or testimony on this? Just wondering if there's any one that could be consulted with to see how that's been working for them.
I haven't had communication with the center nor the Board of Nursing in Washington. The Center for Washington, we had a national meeting earlier this month and they weren't present. So I will, that's a great suggestion. I'll follow up with them.
Thank you.
Yeah. I will note, and I will note the composition of the board. We have 5 members who must be a nurse. They must have an active nurse license, and then 4 members who can be of any background. So of those, because there is a nurse executive in group 1, our board composition today of our 9 members, really at any one point in time, 8, actually all 9 of them could represent unions at the governing level, because we don't have to have it's a suggestion, including but not limited to a nurse executive, an APRN, somebody in a collective bargaining, or doctorally prepared. So, I have had in the past, I've doubled up on some of those areas because I have 5 with 4 spots. And I don't have a specific requirement. So I just want to note that there is that room and capacity now, and I certainly do welcome that engagement. Sarah?
Hi, Laura. Maybe this is a little ignorant of me. The current board is 9, 3 more seats is 12. Do you anticipate that there would be any quorum issues? Not wanting to cast aspersions preemptively, but I know kind of once boards go bigger than 10, I've seen many folks really struggle with having to cancel and reschedule. And I know that it's really a lot of work that you and your staff do because of all the adherence to sunshine and stuff, that it's kind of not so simple as, okay, everybody, let's just meet later today. There's kind of a lot more steps in the process with state boards. Do you think there's any potential for there to be, I guess, issue?
Yeah, thank you for that question. Absolutely. So the center historically started with a much larger board with specific positions, so that there was many of them had, designated roles. And the board is now composed of 9 because of the quorum issues of the past. So it is historical that we have had a larger board that had quorum issues. And if we are not able to if we're not able to meet quorum, we can't meet at all. So absolutely, that would be a concern. I think my other concern is that if we do ever have a vote, we don't have a tie-breaking vote. So if we're looking at Robert's Rules of Orders, normally a consensus is 50% plus 1, but if we're at 50%, we're at 50%. So it's pretty typical to have an odd numbered board composition for quorum. Or not for quorum, but for decision making. Yeah. Any other comments about that section? I have some the questions about and I have not done my due diligence yet. The start of the legislative session, you kind of get all this information in a deluge. So the second section, developing and maintaining a current publicly accessible online dashboard that tracks and displays staffing standards recommended by the following professional specialty associations, and then it lists them. I do have a concern with this section, and that is that many of these documents are behind paywalls. And so I am concerned that the recommendation, I think the intent is understandable. I understand the intent. And if a document is behind a paywall, I feel uncomfortable with breaking what would be proprietary intellectual information and then putting it in a public space. I would have to check with each of those organizations, and that's something that I can do, but I just want to state that I have concern. That said, I also just want to recognize, and I did communicate this to the Hawaii nursing and healthcare professionals when I met with them, that I also see this as an activity that fits very squarely within our second mandate, develop a plan. I'm sorry, I'm looking at the wrong line. Conduct research on best practices and quality outcomes, which is general, but would allow for such activities like consolidating evidence-based information or national best practices. So if you have any comments, I would appreciate them, but I just wanted to share how I am, the angles that I'm looking at this. I think the activity, I would be very happy to convene in an interprofessional group. And those of you who recall the efforts of the Wellness as a Factor of Recruitment and Retention initiative, this, I think, is falls in the same vein of recognizing that workplace environments really do affect the well-being of nurses and the recruitment and retention potentials. And we have spent considerable amount of work doing this. So I think this does fall in line with the center's past activities. I'm uncertain when I read it, I think I'm uncertain if it is necessary to change the composition of the board or the mandates, because I feel like both our board and our mandates are welcoming to this kind of work already. And I welcome it. I think we're more than happy to work. We work really closely with our employers and our nurse educators. We work really closely with our faculty, and I would really welcome this additional work as well. Giovanna.
Hi. So being the newbie here, I guess a comment. I probably have the least amount of letters after my name, but being that I do direct patient care, I worked inpatient and outpatient. I feel like there is opportunity for representation for that type of community here in this board. Maybe that just means more education into how they can apply for this type of positions or be involved. But yeah, I think there is opportunity, and I'm grateful to be here. So that's my blurb.
Thank you. No, we were very happy when you nominated yourself, and thank you for being there or being here for us. And I agree with you. Historically, that has been one of the hardest areas for us to recruit for our advisory board. Getting nurses who still do shift work is nearly impossible to get on a scheduled meeting. It's very, very hard. And so over time, I see that nurses who have moved into kind of 9-to-5 jobs have been able to imagine themselves volunteering in this type of role. But when there is a flexible schedule, I think we just haven't seen the nominations even when we try and reach out. So it is a very hard population of our community to pull into this type of work, which is why we have tried, that's why we've done the evidence-based practice. And that's why we do these other activities with recruitment and retention and the preceptor, the residencies, because we know that our touch points can't only be the advisory board. But to your point, absolutely. I agree with you. Yeah. All right. Well, moving on to the next section. The other bill is the Nurse License Compact. It was a governor's initiative in 2024, and then in 2025, it was not a governor's initiative. And then we're hearing that it will be in the administrative package. It did get introduced. And so the Nurse License Compact, there will be a financial impact to the Center for Nursing if passed. The financial impact, because about 54% of our state's nurses actually reside out of state. If that entire proportion were to have a Nurse License Compact, Hawaii wouldn't see that revenue and we would see that revenue loss. It's not that much, but it could be quite sizable. There also is a small financial incentive. Less than 1% of the scoring is attributable to the Nurse License Compact, but they're trying to get, I believe that they're tying it to the scoring factor. And so there is an advantage both for introducing legislation and for passing it. You get half the points for introducing and all the points for enacting it. There are some additional factors that are new beyond when we did the feasibility and impact of the report on the feasibility and the impact of adopting the Nurse License Compact. Primarily since that time, the licensing division are churning out nurse licenses hand over fist. So 300 to 500 new licensees are issued licenses, or nurses are issued licenses in our state monthly. And so that I'm like so fast that they're not even using the temporary permit process, essentially. So I think that recognizing that the licensing division is very fast, and then we also have been in an emergency proclamation since March 2020, where we have actually been in a state of waiving nurse license requirements if you're a nurse in good standing in another state. So we had all of the COVID emergency proclamations, and then we have had the Lahaina, the response to the Maui wildfires. That said, even if we were to pass a nurse license compact, it would be inappropriate to stop using emergency proclamations in the instance of emergencies, because about a quarter or a third of the nation's nurses have a multi-state license. And in an emergency, you're not going to be like, well, you third are good and you two-thirds. No, we're just banking on them. You welcome the entire environment. So we would still need that emergency proclamation no matter what, because we're going to ask for everyone who's willing to come and help us. And that was a hard lesson learned after the Katrina hurricanes, that a lot of nurses were penalized because of their volunteer work. So I just want to welcome that it's not like a either license, or recognize that it's not an either the license compact or emergency proclamations. We would still need those emergency proclamations. Does anybody have any comments on that or questions?
I think, Laura, I do. It is the case that emergency proclamations don't necessarily include the licensure of healthcare professionals. It did for us because Dr. Green knew enough to put that in, but it's not in law that is part of emergency proclamations, correct?
That's correct. That's
Yeah.
correct. So each emergency proclamation is kind of right-sized to what the needs are, but because there was a healthcare component both to COVID and to the wildfires, the nursing license waivers were put in for both of those.
Neat.
Yeah. Yeah. So, for instance, the Kauai flood emergency proclamations, which exist today, do not have the provision for nursing in it. Yeah.
Thank you.
Any other comments or questions? Cool. All right, moving along. We have our second to last call for public testimony. Is there anybody who'd like to give public testimony? Hearing none. We do need a motion and a second to approve the 2026 Advisory Board meeting schedule. And then we can have followed that by a discussion and a vote. We did work to find the most appropriate or most generally available meeting timeframe. So moving it generally to the first Tuesday. This January we moved because nobody should be meeting on the first Tuesday of the year. And I just want to note that in August, we do bring you all out. If you're a Neighbor Island Advisory Board member, we fly you in for professional development, and then also kind of fine-tuning our strategic plan, which we did not do this past year because we launched a new strategic plan. So we did that 20th anniversary launch. Is there a motion or to approve the meeting schedule?
Is this Linda? I'll make a motion.
All right, we can do Jeanette motion. Linda, can we have you a second?
Second, sure.
Wonderful. Any discussion? All right, I'll do a consensus vote. Everybody say aye.
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 Wonderful.
Aye.
Fast. Great. We are moving along. Upcoming events. If there is anybody who would like to give public testimony on upcoming events, I welcome you. Hearing none. I just want to give that last note. We are sold out. It's so wild. They're like almost doubled from last year, maybe actually doubled from last year. So very, very much sold out and filled to the brim. We're looking at new venues for next year. But I just want to congratulate the team for this really wonderful event that they're building for our community. And with that, I think we are at adjournment. So any other comments or questions from the board? All right. Oh, and except from Bree, she does give a congratulations to Jeanette and Linda. So next meeting, you won't have to hear me talk quite as much. Thank you so much, Jeanette, for nominating yourself for the chair, and Linda for vice chair. And all right, we will see you in a couple months with more updates and requests for information and advice and counsel. Thank you all.
Goodbye.
Thank you.
Thank
Bye,
you.
everyone.
Thank you. Bye.
Bye.
Meeting adjourned.